Two more minutes. Yeah, 2 more minutes to start. Okay. Okay. No, you got a couple of more minutes. You wait. Not to worry.
Good morning, everybody. I feel Houston, I'd like to start the EGM Conference. So this is today's EGM. I'd appreciate if anybody volunteering to start. This is easy, right? Okay. Now it's a regular tachycardia. Heartbeat around above 250 per beat minute. White course complex. Also RPB pattern. It's a region of arrhythmia is coming from left side, and if your rates are negative, it's make from apex to base, I think, and lead one is also negative, right? Transitional zone is V3, V5. I think that is what called complex tachycardia with VT, and from my perspective, it's maybe original side is left. Maybe some or
So, can you summarize what you said so far? Summarize what you've read. Okay. No, we can't hear you.
ventricular tachycardia.
Ventricular tachycardia?
Yes.
From where?
Left side.
Left side.
Left side.
So left ventricle, what you say?
Left ventricle and left superior side.
Left superior side.
Upper superior side.
So you know.
No, it's coming from apex to the base. There, I have three options. inferior mitral valve and left posterior fascicle. The last one is I forgot.
So, who want to comment the next?
White course tachycardia with the superior axis, and AVR is up. AVR is monophasic R, that goes in favor of VT. And it's an RBU morphology, but we have S waves in V5, V6, and one is negative. So it's coming from left lateral wall. Sort of notching in the QRS, likely a scar VT from left lateral.
Okay. Anyone else a different idea?
Well, I agree with what's been said so far. There also seems to be some dissociation. There are these bumps here. Let me pull it over. I think here, there's something here, probably here as well.
Right.
But you don't see it consistently. So I think there's some degree of AV dissociation, which also supports ventricular tachycardia.
Mhm.
The QS morphology and the inferior leads also makes me consider a crux origin as a possible differential.
Mhm.
I also agree that the transition point is around V5, so V4 to V5, which suggests a more apical towards lateral position. So possibly an apical crux VT as a differential.
Okay. Anybody else any more? So let's talk about the cross VT first. Definition of cross VT. What's the character of cross VT? First, lead one, AVL has to be positive. Okay, to be cross. And pure R, no S. Okay, that are already cross VT here. Okay, now, what is the evidence that you have for BT here? Why did you read BT? That's what I'm asking. Not just QRS morphology, but any other convincing evidence that this is not an aberrancy or any other form of tachycardia, delta wave, for example, pre-excitation tachycardia. Do you have any evidence of that?
The extreme axis is one.
Right.
AVR.
Good.
AVR.
The R wave, initial R wave in AVR is another.
Yes. What else?
The prolonged intrinsic deflection suggests the myocardial conduction rather than conduction system, which suggests a ventricular tachycardia.
But also could it be pre-excitation? But to explain pre-excitation, you have to have a multiple pathway. Okay, this one. But if you consider any patient of one pathway, then lead 1, 2, 3, 8 QS cannot be negative same time. So that's out. So, in other words, you guys try to read the ECG, but you need to rationalize why you're reading it, so everybody else can learn. Okay, this is a conference about not right or wrong. Your thinking thought process has to be logical. Okay, then you can say it. So BT is aspect-wise. V1 has what kind of right bundle?
Right.
First rabbit ear possibly bigger than second one is a notching. So, and then deep S wave in V6 alone already tells you this is BT. And then if you look at the AVL, there's an interesting notching phenomenon going on.
Right.
You see that? Now that notching keep going, and then there's a one that has a little longer. Yeah, that one has a small double notching there. What does that mean? Can we talk about what is the HL rhythm doing this thing? What is the HL rhythm going? Clearly, everybody agree VT, but we have to also know what's HL doing. In other words, EKG is get the information, everything out of possibly what you see. Okay, so Fifi point out there is some degree of a discordance, but some notching behind the S segment QRS going on. So that rate is very fast. It's not a silent rhythm. It can be that go that fast. So you may argue, oh, there may be atrial arrhythmia going on. That's very reasonable. Then if you go further into that, you say, oh, could it be atrial flutter? Could it be atrial fibrillation going on simultaneously with this BT, which can influence your QRS duration, also amplitude, because if you have intermittent capture beat, yeah, let's take a look at the lead one. We have to explain why some of them wide, some of them narrow. QRS complex, right? In the BT. So, is it possibly patient have a double tachycardia? In other words, atrial arrhythmia and the BT going on, and the HR, tachycardia so fast, able to conduct once in a while, even during the BT cause a fusion. Quite possible, unless patient are complete heart block, which are unlikely, right? So those things that we need to discuss. So when you read ECG, take a look at it. Also, that is evident in B4. If you look at the B4 end of a S segment, right there, that small notching. Come back, yeah, there is another one, another one, another one. But timing change a little bit, right? So you got a very fast tachycardia going on there. So that much you can get out of this, okay? And why is it wavy, like oscillating? Lead to. Lead to. Continue to strict. Yeah, it's got a wavy thing going on. What does that mean? Either patient is moving, okay? Or patient could be even seizing because the attack is so fast. Okay, so this is the evidence that you can subjectively look at the motion artifact and all this go into the ECG. So just imagine clinical scenario. And the widest complex is where the very first bit leads to. Take a look at how wide that thing is. No, bottom tracing. Yes, and then what happened next? Get slightly narrower. See that? Progressive narrow. Keep going. Yeah, keep narrowing. And then start varying. And then also at the end toward it, get wider again, narrow back and forward. So that is evidence that the probably interaction between upper atrial activity during the ventricular tachycardia going on. Any other comment? I think Dr. Park probably maybe not logged in. He's in Taiwan now, but he's supposed to log in this morning, but he didn't. Okay, he must be busy guy. Anything else we want to add in comment? This ECG from the textbook, Dr. Peter? No. Other hospital. Okay, let's go. Okay.
59
okay.
male, previously healthy, presented to emergency room complaining of palpitations and chest pain. So, after epicardialism, the rhythm went to normal sinus.
Okay.
But he wanted to come to our hospital, so he referred to the outpatient clinic. So we performed.
Okay.
So we
Chest
performed
X-ray.
the London test, radio chest, radiograph, no significant finding. And in order to exclude structural heart disease and coronary artery disease, we performed several tests for all negative. Echo, no significant coronary artery disease, no significant no remarkable findings. Also, we performed cardiopulmonary exercise tests and 8 days of Holter. However, no significant arrhythmia was recorded. But obviously, we had a 12-lead EKG from another hospital. We went to EP study.
Okay.
The EP study, first of all, professor performed the substrate LV mapping, but nothing was found for substrate LV mapping, and then performed the pace mapping. In the patient's mid LV inferolateral wall, specifically anterolateral papillary muscle, there was a 95% matching pace mapping. So successfully, RC was done for the patient.
Did you induce tachycardia during the study? Did you able to induce tachycardia?
I think it's induced tachycardia.
Yeah, you triggered tachycardia during the study,
Yes,
You did?
during the EP.
EP study, and a similar morphology.
Yes.
Okay.
Yes.
There were other things that you did. Did you
Actually,
map with just the LV angiogram, or did you use an intracardiac echo? Anything?
Yes, intracardiac, of course. Yes.
Okay. So, is this anterolateral papillary muscle origin consistent with your EKG finding? Let me ask you that question now. Go back to your WD CGPT. This is consistent with the inferolateral VT. I mean, anterior papillary muscle. That would be trouble for me to state this is an anterolateral papillary muscle VT. Why is that? Because AVL is biphasic. AL is positive. AVL, look at how tall that EKG is.
It's more lateral.
So I don't know whether is echo really show the right thing, but I mean, transition is a V4, V5, so level is probably about right. Has to be below the papillary muscle somewhere. The lead one is a typically negative. 2-3 AVF also negative, except one thing favor for the papillary muscle, the lead 3 has a small R. Okay, lead 3 has a small R wave at the beginning of the VT, yes. Yeah, that may be so. But unless patient heart is rotated, do you have sinus rhythm ECG, this gentleman?
Yes.
Okay, let's take a look at it. So, yeah. Even sinus rhythm is not that. The progression is normal. Okay. So why the patient have S segment elevation V2, V3, V4, V5, 6? What's the reason? In sinus rhythm, also you have a lead 2, limber lead 2. S is elevated. And then, I'm sorry,
No, this ECG is post-procedure,
I don't know.
and so it's post-procedure, and there's also some PR depression and lead to PR elevation, very little in AVR, and then some TP segment sloping as well too. So possibly post-procedure
No, but,
pericarditis.
yeah, but we do not explain why before you have a notching. You see, before has a notching at the Keras complex.
This may be post-cardioversion or an early depolarization.
No, I think it is a post-ablation procedure.
Yes, post-ablation.
So they did not do epicardial puncture. Did you do epicardial puncture in this patient? Did they do epicardial mapping? Or just endocardial approach?
No.
Just endocardial approach. So that would not get a pericarditis. There's not a chance. So is it, would it be interesting to know whether this segment is resolved at the follow for subsequent follow ECG? Yeah, this is not a normal ECG we see. Okay. And then notching, and also I think I have a deeper notching of the V1 through all the way to V3. You can see that small terminal S gets smaller as it goes laterally. So that's anterior precordial lead.
Should it just be early repolarization?
Could be, but then you don't have in the inferior lead 2 consecutively only lead 2. Okay, you need to have a reparative syndrome 2 consecutive lead, in the SPED 2-3 or either 3 and AVF. Not just one lead. I can see the lead 1 a little bit and the lead 2. So is it possible? We should look at the echo image again, make sure that the anterior papillary muscle is the source of VT. Because the papillary muscle VT, the most common, comes from the posterior papillary muscle. That's bigger, the larger papillary muscle. They often branched several head, some of those. Now there is an entity called the interpapillary muscle VT between 2 papillary muscle. The UPenn group published not long ago. And the people have almost like a muscle ridge between anterior and the posterior papillary muscle. And that also has been focused for VT. Okay. It might be a little bit more consistent with that. So I don't know. Maybe there's some consistent change there. Okay.
Can we leave the patient without ICD?
That would be the issue. I think if you're assuming that the patient has no structural disease, okay, you are assuming that they're successful endpoint are clear, probably you don't need to because you have no structural disease. This is a fast idiopathic VT. I don't know how the patient presented in other hospital clinical scenario. I think that would be also influence your judgment whether you do that to do or not. Okay. But patient, if you look at the patient chest X-ray, look at the X-ray. What do you think about this ECG? This patient has a deeper LB dipping into down to the diaphragm. Okay. So dominantly LB X-ray. And the aorta is also a little tortuous, even the heart size is normal. Okay. So that's why your voltage map, your voltage and precordial ECG lead is tall, this patient. Look at that. Looks like almost LVH. That's it. That's because the right ventricle is not big, this patient. Left side is dominant. So EKG sometimes can mislead. And then also lead 1 has a very deep, narrow, complex Q wave. You see that lead 1? Yeah, that's not normal. Patient was big significant subtype first.
One also came in.
Yeah, so I think need a review. Like look at the careful echo image. Okay, I'm sure it's correct, but that's very unusual. Okay. Yes, but interesting, very interesting case. So what to do?
Plan was documented the developer,
Uh-huh.
and in event of VT reoccurrence,
Uh-huh.
he could be the
I
very
can.
good candidate for ICD.
You don't have any clinical information from other hospital. He presented besides the chest pain, any syncopal episode, anything?
But he required cardioversion, right? He was given the unstable and cardioversion was needed.
They don't know. Yeah, because many management in Korea, hospital differences. Okay, depends which institute you go. Some people will try to treat it with medication first and try to make differential diagnosis. But emergency service people, they just want to take care of the problem, get over with it. So that tended to be shock first many times, right? But all depend on community level care and then also the academic institution. Even university setting, sometimes they don't do complete evaluation before calibrate the patient. Unless patient very unstable, then doesn't matter. We have to calibrate, right? That's why I ask and see what is the presentation clinical picture. That will decide whether the patient needs ICD implantation or not. Okay. But if the diagnosis is correct, is a papillary muscle, you're assuming focal VT. And that may explain why a slightly irregular VT, not monomorphic regular VT. Okay. That may favor for the focal VT. If you look at your clinical presentation, you see somebody rather regular, but it's not irregular, slightly irregular. Do you see it? Especially in AVL. Take a look at it. So there is some acceleration, deceleration issue going on back and forward. But that could be also fusion from upper. So those things, especially V6, you can see the acceleration and slow down a little bit too. So this favor for the focal VT, but then again. Now if you think about if you have a more fusion phenomenon during the VT and the irregular, that means most like a mechanism is more focal VT. If you have a re-enter mechanism, very hard to penetrate tachycardia during the fast tachycardia circuit from the supraventricular rhythm, make a fusion. Okay, makes sense? Because your tachycardia circuit is long. Yeah. So those things may favor for the focal VT. Okay. All right. Thank you so much for the wonderful case. We still got a time, 10 minutes. So any question you guys have, you can talk about it. So remember, Crux VT, lead one, AVL has to be R, no S, you are straight up. Okay. And then 2-3 AVF can vary a little bit, especially leader 3. Most of the Crux VT are QS, leader 3.
Let's start. Good morning, everyone. This is Daeun Kim from Korea. Thank you for joining our monthly international EP Case conference. Today, we are pleased to have Dr. Nae Aung Win from #1 Defense Service General Hospital, Yangon, Myanmar. And we have panel Dr. Taeyeon Hwang serving as our panelist from Severance Hospital. Let's begin the session. And Dr. Win, please. You can start, Dr. Win. Dr. Win, you were
I think she
sharing
she has some
slides, but
network problem.
okay. Okay, we can see your slide. Okay, you can start. Thank you for coming back.
Can you hear my voice?
Yep.
Yep.
Yeah. So good morning, Dr. Huang, professor, senior and junior colleagues from every country. So I'm Dr. Wen from the #1 Defense Services General Hospital, Yangon. This is a case summary. 50 years old lady, 35 kg in weight, 157 centimeter in height. She came from the middle part of Myanmar, and she was a known case of the PSVT, presented with a palpitation off and on for more than 3 years. It was sudden onset, lasting about 2 to 3 hours per episode, and associated with the shortness of breath and the dizziness. PSVD was terminated spontaneously or with the IV adenosine, and her regular medication was verapamil. And this is the documented tachy ECG. ECG show a narrow complex tachycardia with the pseudo R at the V1, and maybe this is the retrograde P at the 2-3 AVF. So this is the short RP tachycardia, likely the AVNRT. And this is the baseline ECG, sinus rhythm, partial RBBB, and no pre-excitation. Chase ratio are tubular heart, low fret diaphragm, and the hyperinflated lung compatible with the obstructive lung disease. Echo show a normal LV function and no stretch heart disease. EB study and RFA was done on 26 February this year. And this is the baseline ECG. And this is the baseline intracardiac electrogram and the baseline catheter position. And the two quadripolar to his and the RV. And the ablation, non-irrigated ablation catheter to HRA. And the decapolar catheter to CS. And the baseline conduction intervals within normal limit. Our sinus node recovery time was also normal, and the retrograde steady RV bus pacing 400 millisecond show central atrial activation, concentric atrial activation with the RSA at the HIS. So RV straight pacing 350 millisecond show fast pace speed when V to A goes through the with the VA jump with the RSA at the CS56, and the second pace speed was blocked, and the third pace speed V to A goes through the fast pathway, and the RSA at the HIS. And during the retrograde conduction, VA interval decrementing, and the VA ERP was at the 500-350 millisecond. And the integrate steady HRA straight pacing 450 milliseconds show a progressive lengthening of the AH interval. And one extra from HRA show a documented response with a smooth propagation of the AH interval without significant jump. And the AV ERB was 450-300 milliseconds. The two extra from HRA, there's a fast jump at the 500, 450, 300 millisecond, and the second jump at the coupling interval of the 280 millisecond, and the slow power ERP was at 500, 450, 360 millisecond. So HI straight pacing induced the tachycardia and the isopra, and tachycycline was 250 millisecond, long H interval, short HA, and the V interval was 26 millisecond, and the RSA at the HIS distal. So ventricular override pacing terminate the tachycardia, and we induce the tachycardia again by the HI bus pacing. Another tachycardia with a cycle length of the 330 millisecond, long AH, short HA interval with the ultra short VA minus 35 millisecond. So RSA at the HIS. So HIS repetitive PVC cannot advance next A and cannot reset the tachycardia. And ventricular override pacing show the VAV response with a PPI minus DCL more than 115 millisecond. So summary is a dual AV nodal physiology with a multiple slow pathway, 2 retrograde pathway, fast and slow, and 3 antigrade pathway, fast and 2 slow pathway. Tachycardia was induced by the A-bar spacing, tachycycle length 350, 330, and 250. Both tachycardia has a long age, short HA, and the earliest A at the His. EP maneuver, His rapid BBC, and VOP indicate this is AVNRT. So we decided to play the slow pathway at the RIE area. So this is the RFA1 and the fractionated A and the ADV ratio is okay. And fluoroscopically and away from the His between the tricuspid annulus and the CS os. So EGM is right and fluoroscopically right. So we decided to break here with a non-irrigated catheter, 30 watt for 60 seconds. Just after starting the ablation, there's a junction automaticity. So we paste from the CS to monitor the VA to V connection. But post RV study, tachycardia was induced, readily induced with the CS 550-300 millisecond and earliest at the His. So we try to break at the RE area, but the tachycardia was easily inducible with the tachycardia zone CS 550-300 millisecond. And although radiofrequency ablation at the RE area get a junction automaticity, but the AVNRD was not terminated. Therefore, we review the tachycardia for the possibility of AVNRD using the left inferior extension. So this is sinus speed, and this is PAC, and the jump, and the tachycardia start. And earliest activation was at the CS 3 and 4. And another tachycardia, I think earliest at the CS 5, 6. So we try to ablate and the CS for the LIE. And we did the CS phenogram first to know the CS anatomy, where is the CS catheter, and where is the roof of the CS, where is the flow of the CS. So RFA to the CS roof at the 3-4 and the 4-5, because retrograde RDSA at the sometimes is a 3-4 and sometimes a 5-6. Using the irrigated ablation catheter, 35 watt for 30 seconds. And we test again. There's a stay EHM at the 550-320 millisecond with a 1 echo up to the 550-270 millisecond. So echo zone is a 50 millisecond. And tachycardia cannot be induced with or without isobray from the CS bus spacey and with two extra. So my final diagnosis is a slow fast AVNRT using the RIE or the LIE as an integrated lamp and slow AVNRT. I think we did the successful slow power modification to both RIE and the LIE. And then we will stop the procedure because tachycardia cannot be induced with the programmed electrical stimulation. So any discussion?
Hey, thank you for sharing your beautiful case with beautiful venogram. And okay, I would like to invite Dr. Huang to share his discussion. Junior Huang.
Yeah, hello, my name is Taeyeon Hwang, and thank you for sharing your very excellent case. the case, and I have several questions about the procedure. The first, was there any particular lesion that you select the initial diagnostic catheters because you did not position the separate right side atrial catheter at the beginning of the procedure? And second one is, you mentioned the multiple slow pathways, but could you explain the findings that led you to interpret this as the multiple pathways? And finally, when you do the initial slow pathway modification, you mentioned the fluoroscopic guided ablation, but did you see any the slow pathway potential during the ablation? So there's three questions.
Yeah. So and this slide, this is the first jump, the coupling interval 300 millisecond, and another jump at the coupling interval of the 280 millisecond. So I think there's a two jump and the integrate steady. So I think there's a three pathway goes A to V, fast pathway and a slow pathway and another slow pathway. And the retrograde steady, the fast pace beat, pace beat. There's a VA jump, RSA at the CS 5-6. Second pace beat was block, and the third pace beat, there's a RSA at the his, so slow pathway and a fast pathway, I think.
How about the last bit? It's also says 7-8 and his is similarly early. Last VA.
Here,
No, last bit, last
Last
pacing.
bit.
here,
Yeah, there.
at the same time between the his and the CS.
How can we explain? It's you mentioned the first pathway, retrograde first pathway is distally, right? At the last pacing bit, the CS 5, 6, 7, 8, and east distal. This timing is all
Same time, you.
very similar. So I just curious.
I think the 5, 6, and 7, 8 of the last bit shows the polarity reversal, so there might be some kind of left inferior extension, but I'm not sure.
But this is also the VA jump. It's not the first pathway, and
Yes, I think this is a VA jump. Maybe.
okay, you can go on.
Yeah.
I apologize.
I think ablation signal R1. I think ablation proximal signal is more, I think more good because of far VA and there's a slow power potential in here. But there's a two separate potential and the ablation tester, the very sharp potential, two potential. I think this is the slow power potential, and I played that. And just after ablation start, there's a junction bit in here.
Is
So
it
I think
junction or PVC?
Mm.
junction or PVC, maybe. Publishing digital V is earlier.
Yes, maybe PVC.
And okay, and that's it. Oh,
Yeah.
Also you did the CS venogram and then additional ablation at the CS roof. Can you show what's the can you show us the ablation of the CS roof? Is there electrogram?
I no knows. I did the play the anatomically because during the AVNRT earliest A is at the sometime CS3 4 sometime the I6. So I played here.
Is this the same position of the CS decapolar catheter? Because I think the CS catheter is slightly pulled back, so
Yeah. Maybe.
the initial CS 5, 6, and 7, 8 was the earliest during the V pacing and retrograde, but I think the movement of this diagnostic catheter. So okay, so it was better if you can show us the ablation of this with the EGM, then yeah, maybe.
Yeah.
So thank you, great job.
You do not paracetal pathway.
You can ask them. Don't ask me. Ask those guys. There's a speaker. Yes. Anybody?
Question from Severance, please.
When you had a repeatedly induced A on V tachycardia, did you try to rule out a paracetal pathway?
Septa pathway.
Yeah, with earliest A in 3-4. Did you do first to rule out a septal pathway that can resemble an A on V tachycardia with earliest A in 3-4?
But V to A endeavor was very short, and PPI minus DCL is more than 115. So I think this is AVNRT. But I didn't perform the Parahesian pacing in these patients. So and also he's referee busy, cannot advance the next A and cannot reset the tachycardia. So I think this is AVNRT. AVNRT.
Okay, I apologize for putting you on the spot with so many questions, Dr. Win. And yeah, I would like to also invite any additional comments or questions from the audience, other than Severance, our international colleagues. Any comments or questions? Please feel free to share your thoughts. No question? No comments? How about Senior Huang?
Okay, let's go over the case. Dr. Wayne, let's go to the case first. Go first slide.
Oh, yeah.
Let's dissect the case. So you have a 50 years old lady, very
Yeah.
skinny, 35 kilogram, only weight 35 kilo, even the patient 154, right?
Yeah.
So this is a very unusual, almost nutritionally very poor lady. Okay. So she having tachycardia and then she smoke and verapamil. Okay. Next slide. So this tachycardia, what is unusual about this tachycardia? It's a rate.
Yeah.
It's slow, right?
Yeah.
It's rather unusually slow 50 years old AVNRT patient. So question is, and then also you can see very distinctive P wave right at the end of a QRS complex. This is also unusual, right? Sometimes they are hidden so you cannot see.
Yeah.
Why do you think that you can see P wave, such distinctive way? What are the potential mechanism you can see? Because this lady has what? Short QT, right? Look at the patient doesn't have a S segment, just R and T. That's it.
Yeah.
And those patients, because the inferior lead repolarization, this lady is inverted, then your P wave is a more positive initial component that you can see very nicely. So rate issue, also repolarization issue. Okay.
Yeah.
So let's, and then your 12-lead ECG shows what? Which is the maximum deepest? Now go back there, tachycardia. It's unusual about this ECG. What do you see? Transition is not normal, right?
Yeah.
Late. B4, V5, R wave. Right?
Right.
Okay. Go next. Sinus rhythm ECG. What it shows? Transition, still a little bit late. What does that mean? Patient has right ventricle overload, right? That's what
Yeah.
that means typically. And that's what the change in repolarization you see. Okay. And then chest X-ray. What is this heart? You think? This heart normal shape?
No, tubular heart because
What
of
else? What else? Where's the apex, this patient? Patient has a slightly rotated heart also.
Yeah.
Okay. Half dextrocardia almost. That's why you don't see apex. Even in such a skinny chest X-ray, I should be able to see an X-ray PA slightly apical of the left ventricle. I don't see it. It's round. You see that?
Yeah.
Yeah, that's not a normal X-ray. Okay. Even the heart is small. Okay, you point to that pendulous heart. That's fine. Okay, next. So sinus rhythm, same thing. Delayed transition. Keep going. So what is unusual about this your catheter placement? First thing you need to notice. CS is what? Very vertical, as we expected, right?
Yeah.
You don't see CS like that typically. When that your CS is vertical, they become what? They are closer to the AV node, right? Because this kind of squeeze in. So your compact node, his bundle, potential flow pathway area are going to be pretty much very close to each other. Okay. And then which you seen on the your venogram. Okay. Go to venogram. That's you did shoot the venogram and LA of you. Show us a venogram. Where you might think, where's your his bundle? In the area view. In us. Right above it. Okay, they're very close. So this is the kind of patient that you may increase the risk of a heart block on your latest flow pathway. Okay?
Yeah.
Yeah. And you can see MCV almost straight down, almost like a pulsar range, but that's MCV. you point to the right. So then your his bundle right above it. Fortunately, you did not have a good his bundle potential, your catheter. So I don't know what the AV node is, but it should be around there. It's very close. Okay? All right, keep that in mind. Let's go to the tracing now. So anatomy is important to interpret this tracing. All right. So you had the sinus rhythm, and then your baseline conduction, and you had a small his bundle, your HV interval normal, right?
Yeah.
Okay, keep going. Next slide. So you had the S1, S2 here, sinus recovery time normal, you said, that's good. And patient, keep that in mind, the patient right bundle branch block, okay? That's important now. During the V-pacing, okay?
Yeah.
His bundle is earlier. But if you look at your baseline catheter placement, where's your catheter? You think in an RV, when you put an initial catheter, your RV catheter was in septum.
Septum, yeah.
Yes. And then you can notice your RV EGM very sharp potential at the beginning, and then kind of a fragment potential there. So that is a septal potential, which close the right bundle. But luckily you had the right bundle branch block, right?
Yeah.
What I mean, when you pace the septum, it's going to come through the left side first, because your right bundle is blocked. Make sense?
Yeah.
So that enhances your his bundle earlier day. Okay?
Yeah.
All right, keep going. So here, what do you see?
I think,
you got a VA Wenkiba. Agree?
Yeah.
The first bit, no capture. Okay? There's no VA conduction, first bit. Second bit, capture. Then which is earliest?
CS56.
CS56 and septal A the same time.
Yes.
Okay?
Yeah.
And then next bit, what happened? Septal A became earlier.
Yeah.
And then next bit, blocked. All right?
Yeah.
Typically, we would see different way, right? Typically, we would see first bit conducted the Wenkiba, septal A first, second bit when the fast block and they go to slow. This is reversed. Why do you think it is? How do you know it's reversed? Look at the CS EGM. First bit and last bit and the second bit and the fourth bit, the last on the screen conduct. They are same potential. 5, 7, and 8, very sharp potential at the beginning. Do you see it?
Yeah.
And then second bit, after bit, does not have that sharp potential. Matter of fact, that potential became negative. How do we explain this? So D7, the first bit, conduct through the left side septum. That's most like slow pathway. And second bit, third bit that you conduct, also same, but the second bit conducted through the fast pathway. Because the patient has what? Right bundle branch block. Okay? So right side input is delayed here. So yet actually first bit is the fusion between fast and slow. Second conducted bit is only fast. Last bit conducted the fusion. Okay?
Yeah.
That's explain why the CS EGM changing, his bundle EGM changing, all this. Clear? So
Yes.
it is important to look at the EGMs of CS and his together, not just the earliest or later business. Okay?
Yeah.
Okay. Go next. So what do you think about this? This is a fast pathway, right?
Yeah.
It's earlier. And then VA block. You think it's VA block?
Yeah.
No. VA echo bit. Very long conducted CS is earlier. And then look at the P wave. Inverted. These two. Do you see it?
Yes, sir.
The long jump with the echo, single bit. And then this is the CS is slightly earlier. Okay?
Okay, sir.
So this patient has a red target dual the physiology capable of a single echo. That rules out what? Septal pathway. Earlier question you had. What else?
Yeah.
Septal atrial tachycardia as well. Okay?
Okay, sir.
All right. Let's go. Next. Here, what do you see? Antegrade conduction, progressive longer, so the antegrade decremental, right?
Yeah.
Unfortunately, you don't have a Hismondo potential. We love to see that, but you don't have it. So, but I think it's decremental. Okay, let's go next. So you had a jump here. You showing, correct? Or not? No jump.
Recommended no jump.
Okay, next. Here, jump.
No jump.
No jump.
Yeah.
Okay. And the next one, the ERP. Okay. Now here you said the jump. So 320. Next one is the 300. This would be a problem if you present the case to the scientific meeting. Jump definition is what? 10 millisecond interval, not 20. So nobody would argue that, oh, you can prove this a jump. Okay, you have to say 320, 310, then jump. And then should be 300 to 290 jump. Okay, but most likely jump. But interesting about this jump is what? Septal A, EGM. Look at that. How early that it is. Septal A. Do you see it? Septal A is earlier. Different than your initial jump that we saw during the VA conduction. How do you explain this? Oh, this is a junction escape rhythm. You got to prove yourself. Okay?
Yeah.
So I'm not sure this is a jump. That's what I'm trying to argue here. If it's a jump, should pass through the slow pathway. Therefore, CS should be earlier like before. But it's a Septal A is earlier. And EGM is completely different. You can notice that when you had the first jump and second jump, EGM exactly the same. Only difference is what? Second jump, AV interval slightly longer in my eye. When you had the 280, that hits A to the following septal V, slightly longer than first one. I want you to measure when you finish the case. Go back, take a look. This is junction escape rhythm, most likely. That's how I would argue. Okay? Okay, let's go. So this is AV node ERP, okay? So this is a second slow pathway. What do you mean slow pathway? There's no second slow pathway ERP here. Okay, keep going. Yeah. All right, so you induce tachycardia. Now look at the tachycardia induction. I want you to follow the A. Okay? He said. Yeah. He said that sharp guy or small guy? What do you think? Sharper guy, right?
Yeah.
And this tracing shows that the CS is clearly earlier, right?
Yes.
Which is different than what you show in jump. That's the argument against your tracing. So this patient has AVNRT, agree, but then earliest activation is CS 7-8. 9-10, you don't have a signal, so I can tell. But then I want you also look carefully. 7-8, 5-6 has what? Proper polarity reversal. Okay? And then 5-6 has a very sharp fragment signal, which is early too. Doesn't belong to local A. You can see also in 3-4 that sharp potential, like a pathway potential almost. Do you see that?
Yeah.
Okay. That's a suspected area. Okay. Let's go next. Keep going. Okay. Keep going. And then this is the same thing. What happened here? Why do you think the septal A became early here? Because his catheter moved. Okay. Your catheter probably dropped to the posterior septum. I almost bet the money on it because the A signals are too big. EGM changed here. Your catheter moved during the case. That's all this confusion is going on. Okay?
Yeah.
All right, keep going. And so you did the VX right here, right?
Yeah.
And then what happened? So here, which were A, he say, did they move? He said the more posterior did not move, didn't do anything. V got a little bit pushed forward, but then tachycardia didn't change at all. So it did not reset. Okay? So that's favor for AVNRT. Fine.
Yeah.
Next. So then you do BOP, that's fine. You hit that, keep going. So you just summarize. So I don't know whether you have a too slow pathway here. Okay?
Yeah. Yeah.
Because I don't know whether that's a true jump. Maybe it's a junction escape rhythm. maybe single pathway, slow pathway evidence with the AVRT. Okay, go down. So you did the side ablate. Okay, what's wrong with this picture? I assume one is RAO, the other was LAO view. Okay?
Yeah.
Why your ablation catheter the same line as his in LAO view? That's another way slow pathway is. Your slow pathway should be a little bit higher, closer to the electrode 7 and 8, and then should be left than his bundle catheter to see posterior subtle. Okay?
Yeah.
So this site is not a good site to ablate. Second, is too low. Remember, usual venogram that they are pretty much crunched together. So it should be higher, more leftward. Okay?
Yeah.
Yeah. So you look at your compare picture. Okay, go to next. So during the RFA, you had, but go back to the ablation signal. You had the ablation signal there. Did you do for, yeah. This ablation on, RF on, that's catheter induced by probably PVC. How do I know that? Because the ablation distal has early signal, and then that's a subtle PVC, crux PVC almost. You see that?
Yeah.
That is your catheter induced. Okay. So that is not a junctional rhythm, like Dr. Kim already commented. Okay, next. And then you did the venogram. Okay, you see during the ablation you got a lot of PVCs, so that means catheter is still hitting the ventricle. Okay, keep going. So then you still induce tachycardia, same. Okay, now his bundle catheter moved again. Your EGM changes a little bit. Okay, now his is probably slightly later than before, but still you have that sharp potential in 5, 6, 7, 8, right? And CS, you see that first beat. Okay, keep going. And then you do number 3 ablation. I don't know where this is inside or CS or not, but it doesn't look like. Okay, keep going. 3 easily inducible. Okay, keep going. Tachycardia haven't changed at all. Keep going. There's a small sharp potential. So keep going. Okay. So keep going. Now CS is earlier, this tachycardia. Okay, this is CS is earlier. Keep going. So then you do venogram and keep going. You do the ablation inside. For me, if I had to ablate this tachycardia, I would pull back this CS catheter, ablation catheter, I mean, more proximal, 7 and 8.
Oh.
That would be a little bit left to the his bundle, and then should be below the his bundle. Because you're pulling out, you're going to be far away from the AV node, right? Because coming down.
Yeah.
That avoids the risk of heart block. Okay?
Yeah.
So in LAO view, your catheter, ablation catheter, should be between halfway from the CS os and his bundle catheter. That's typically where we ablate slow pathway. Okay?
Yeah.
So I think this patient has some anatomical variation. Difficult to look at the EGM, but I think single slow pathway, you could be ablated from the little bit more proximal. Then you'd have a junctional rhythm and beautiful tracing. Because that's the reason you do not have any junctional rhythm during the tachycardia ablation. Okay?
Yeah.
That's what I can tell you. All right? Good job. Thanks for the wonderful case. Okay. Anybody has any comment, please ask a question. I'll do that now.
So I have a question.
Yes, please.
The slide that suggests the 2 jumps.
Oh, you sure? Ask him, sure.
If you could please show that slide, the one that suggested the 2 jumps.
Yes. Keep going. Double jump. Yeah, that one.
Yes, I'm wondering because the impulse will go through the slow pathway and still go through the AV node, which still has decremental property. So my question is, the AH interval in the 500, 450, 300 and the 500, 450, 280, is it necessarily 2 different jumps, or it could be slow pathway conduction plus AV node artery condensation causing that difference?
Go ahead. In order to have a two slow pathway jump, your CS EGM have to change. Okay, that's a requirement. Second is that if indeed we say that this is a rightward extension, change to the leftward extension, your CS need to be more eccentric. Second jump. That's a criteria. You don't have here, right? That's why I argue probably coupling dependent junction escape rate. That's to explain why he said earlier. CS EGM didn't change at all. Okay, that's the reason. So every time you have an echo, it has to have some degree of fusion between septal A, posterior activation A. When they become more shorter, S2 gets shorter, you will see more pronounced CS activation than his bundle. Okay? You need to show that degree of eccentricity. Yeah. In other words, anterior input versus posterior input, posterior become more markedly pronounced compared to anterior input. But always there's going to be some fusion. Okay? Because fast pathway conduction is going down to the anterior aspect of the AV node and then where the common bundle is. So fast pathway don't have to go to entire AV node to conduct to the ventricle. Slow pathway, the other hand, come down to the crista and then posterior isthmus, and then you go to the posterior extension going to the compact node. Therefore, this differentiation has to be demonstrated. For that reason, you need to put a catheter in proper place as well. So that's why so important to have a his bundle EGM, okay? So I tell you again, when I was a fellow, we used to do this, I used to hold the his bundle catheter for 30 minutes to do this. Okay? This is how you just put it in. Okay, good. Let's do it. No, it doesn't work that way. If you want to do a beautiful SBT case, please, you will need to stabilize a catheter. Second thing that we did, I don't know whether you guys seen it or not, there's a venous sheet that you have a locking. Okay, head. 7 French venous sheet, we put it in, has a locking head, we put the catheter, lock it, so it doesn't move around. And then we put a tower at the top, do whatever we need to do, maintain good his bundle EGM AV ratio. That would give you beautiful traces. Then we do not have all this debate we're talking today. Okay?
Yeah.
Any other question, please?
Good morning, Dr. Huang.
Good morning.
May I ask you one question, please? So,
can you introduce yourself? I don't know you.
it's me, Heng.
Yeah, it's you, Hank, but you got other people that don't know you, so you better, introduce. Okay, go ahead, Hank. What you need?
So may I know what is your approach to the left inferior extensions of the slow pathway? What the ablations? CS first or left side, left central transseptal puncture first? And do we need to target the earliest age during the V-passing and find the retrograde slow pathway conduction first or anatomical approach?
Okay. There has several different manifestations related to the leftward extension part of a critical circle tachycardia. You can vary earliest A exit from even lateral wall of a mitral valve. Professor Jackman showed some cases, or between and only localized leftward extension involving only left posterior septum. Okay? Honest with you, we do only maybe 1 to 2% a case of AVNRT, a typical one that we do transseptal head to ablate the leftward extension. You have to remember leftward extension, rightward extension involved any tachycardia. Only difference is that where the insertion point is the atrial exit of those pathways. So if you want to ablate the leftward, easiest thing would do transseptal and then ablate the left side of the slow pathway. That would be easiest. But sometimes that does not work either because this leftward extension not necessarily close the left side endocardium. We think left side because it's a closed endocardium. No, sometimes leftward extension so straight down to the middle of the septum, come down directly to the CS. Then you have to ablate inside the CS. So I think a careful mapping is important. Number one, if this problem becomes that serious, I recommend to put out another decapolar catheter inside the CS, one in the roof of, make sure that it's touch the roof of a proximal CS. In other words, you need more further detailed mapping of that area other than just one CS catheter. The reason being, AVNRT, CS also is quite larger than normal people. Second, ostium tended to be also much larger. So maybe it's just putting one diagnostic catheter, CS, may not be enough. So that's why, Jackman's lab, they put invariably 2 catheter or even 3 sometimes to see those areas. For pacing purpose, for confirmation purpose, many other reasons. But sometimes you look for left side mitral aneurysm endocardially everywhere. You cannot find that sharp potential that you saw today on the CS 5, 6, 7, 8. And that is, you need to search inside the CS. You target that sharpest potential. They usually get rid of a pathway. Okay, that much I can tell you. But this AVNRT for us still very enigmatic animal. We do so many of this, still don't understand complete tachycardia circuit. We know where the exit site it is. We know how the conjunction is, slope at the potential is. But between leftward, rightward extension, where they turn around, nobody knows yet. We haven't been able to map that pyramidal space because we don't have a mean to do that yet. Okay? Did I answer your question?
Yeah, thank you so much.
Okay.
You mentioned that the best place to ablate is between the CS pause and the his in the midway. But my understanding is that the compact AV node sits just below the his, and that's the mid-septal part and very prone to AV.
Okay. If you have a proximal CS where the funnel shape is, if you ablate the roof of that, you will have a heart block. Okay. Now, some patients, they have such a sort of a shallow or narrow range of tragus venous. If you look at them and you try to ablate the roof of that CS, you'll be problematic. So we don't ablate roof of CS. We are looking for slope at the potential before you ablate. Anatomic site, when you get there, you should able to see slope at the potential there, then you ablate. Not just roof anatomical. We don't do anatomical approach. Even though we are talking anatomical location, all AVNRT should be done under the slope at the potential guidance. Okay? And then also, they did it right when you just junctional rhythm, you suspect junctional rhythm, just pace, make sure that your fast pathway is intact. That's a safety word of the guarantee that you have no heart block. Okay? Again, AVNRT is a potential guided ablation based on the knowledge of anatomy evaluation, that particular variation of patient. And there's no same patient, AVNRT. Every patient different. CS different, location different, EGM going to be different. So you just have to map it, learn, figure out where it is and ablate. Okay? There's a, really, I have not seen single heart same in anybody in the world yet. So keep that in mind. So learn the heart first before you play with it. Every patient the same. You get used to it, the catheter motion and all that, then you can start ablate. Not before. Okay, sir. Any other question, please?
Dr. Wong,
There's a
can we
question.
conclude this tachycardia?
There's a
this...
question there.
Yeah, I have a question.
No, they're in the chat.
Yeah.
Chat. Who that is?
It's from Kyo.
Okay, what it says now?
Is there any use of ISO to induce tachy after final ablation? To win?
Pardon me?
Did you use isoproterenol to induce tachycardia after final ablation?
Yeah, yes.
But
Okay.
no induction after final ablation, right?
So after final ablation, we perform CS pass pacing up to 200 and the isopre. So 2 extra with isopre after the RFE. Tachycardia was not induced.
Okay.
All
Thank
right.
you. And can we conclude this tachycardia?
No other question, I think, Dr. Kim.
One more question? I have one question. left inferior extension
Please
really
talking, but
participate
muted.
this
Professor,
tachycardia?
please, you are muted.
Hmm? Do you hear me?
can hear you, Professor Kim.
You have some.
He's done already, I think.
Oh, there's a problem from our side.
Maybe that we are not listening. Oh, speaker, what is that?
I disconnected and reconnected.
I think it takes some time.
Do you hear me now?
Yeah, we can hear you. Sorry.
Okay. So can we conclude that left inferior extension really participate in this tachycardia in this case? I just asking.
I don't think there's a leftward extension involved by evidence here because coronary sinus anatomic variation is vertical. So I think the slope pathway probably more than usual more to the left side. I think that's what it is. Okay.
Okay. Okay, if there are no further questions, we can conclude today's session. Thank you for all your participation, especially Dr. Win, and look forward to seeing you at our next conference. It's May 2nd. Okay, thank you.
Thank you.
Thank you.
All right. Good work.